Hello students, welcome to this video. Here I am going to start a series. Yes, series of biochemistry clinical questions. Now the trend is clinical biochemistry. So questions are gonna be this pattern, USMLE pattern. Okay. So this is part 1 of our NEXT pattern series. I will be taking 10 questions in this video and I will be covering the following clinical cases. First, phenylketonuria we will be covering, then non-classical phenylketonuria, then carcinoid syndrome, lead poisoning, acute intermittent porphyria, homocystinuria, PUFAs, that is polyunsaturated fatty acids, Sandhoff's disease, Wallmann's disease, and infantile respiratory distress syndrome. So we will be covering all this in this video. So let's get started from the first question. So these are gonna be lengthy questions, so practice reading, and in this video do read with me carefully. A two-year-old boy brought to clinic because of poor development as well as vomiting, irritability, skin rash. So the patient has some skin rash. That's an important finding. Then the boy's mother also notes that his urine has a strange mousy odor. So our answer is very easy now when mousy odor is given in the question. You know what I am saying. Okay, let's read the full question, then I'll be telling you the answer. Then, physical examination reveals the child has an eczema-like rash. The child is hyper-reflexive and has increased muscle tone. So, exaggerated reflexes and hyperactivity. He has surprisingly fair skin complexion compared to the rest of his family. Very important sign. What is the most probable diagnosis? So, our diagnosis can just come from one word of the question, that is mousy odor of urine and body fluids. And these patients are patients of phenylketonuria, right? So, what is the defect in phenylketonuria? The enzyme phenylalanine hydroxylase is defective. This enzyme converts phenylalanine to tyrosine, right? So, when this enzyme is not working, tyrosine is not formed, and tyrosine forms pigment melanin. When melanin is not formed, that's why this patient has fair skin as compared to rest of his family, right? Then, now when this reaction is not occurring, phenylalanine will accumulate and it will form phenylalanine products, some other products of phenylalanine like phenylactate, phenylacetate, phenylpyruvate, right? Now here I am gonna tell you one important thing, that due to phenylacetate, these patients have mousy or musty odor of urine. In Hindi, it's called basi or purana, old, okay. So that kind of odor, that is because of phenylacetate, and because of phenylpyruvate, these patients give ferric chloride test positive, which is done in urine, right? Then, due to phenylalanine, these patients have mental retardation, and usually these patients of phenylketonuria have severe mental retardation, right? Then, the question is mentioning about some rash. These patients have usually scleroderma-like rash. This rash is because the products, phenylalanine breakdown products, they are photosensitive. Many of the phenylalanine breakdown products are photosensitive. That's why these patients have rash. And other clinical features are, in early stages, these patients have just increased muscle tone, increased reflexes and hyperactivity, right? Because brain is affected, okay? But later stages, they have severe neurological sign and symptoms, like seizures and mental retardation. And these patients have microcephaly. They have microcephaly, you can see this picture. And some other clinical features are wide spaced teeth and enamel hypoplasia. Right? If you know all the clinical features of phenylketonuria, it will be very easy for you to diagnose this clinical case when given in the question, right? Coming to question number 2, a 4-year-old child was found to have developmental delays and severe mental retardation. So, brain is affected and patient has mental retardation. His blood showed high levels of phenylalanine and phenylpyruvate. So, phenylalanine, phenylpyruvate is increased. So, it's looking like a picture of phenylketonuria only, right? The child was given a low phenylalanine diet which did not improve his condition. In classic phenylketonuria, if we give low phenylalanine diet, the patient improves. But in this case, they are saying that this patient was given low phenylalanine diet which did not improve his condition. Means it's a case of non-classic phenylketonuria. Keeping this information in mind, which one of the following conversions is not occurring properly in this child? Let's see the options. Dopa to melanin. There are multiple steps and reactions involved in conversion of dopa to melanin. Then tyrosine to dopamine. Here, first tyrosine gets converted to dopa, then dopa gets converted to dopamine. Here the enzyme is tyrosine hydroxylase and here it is decarboxylase. Okay. Then serotonin to melatonin, there is acetylation and methylation step. Then norepinephrine to epinephrine, there is methylation. So, we will come back to these options once again. First, let's see what is non-classic phenylketonuria. See, phenylalanine gets converted to tyrosine. Enzyme is phenylalanine hydroxylase. If this enzyme is defective, it is classic phenylketonuria. Okay. Two more things are also required in the conversion of phenylalanine to tyrosine, that is tetrahydrobiopterin and NADPH. So, tetrahydrobiopterin gets converted to dihydrobiopterin. Then we again need to do the reduction here. So, enzyme is dihydrobiopterin reductase. This enzyme uses NADPH. So, NADPH gets converted to NADP, right? Now, tetrahydrobiopterin is derived from GTP and the enzyme is GTP cyclohydrolase, right? Now, non-classic phenylketonuria can occur due to defect in dihydrobiopterin reductase and GTP cyclohydrolase. If there is defect in dihydrobiopterin reductase, it is non-classic phenylketonuria or phenylketonuria type 2 and 3. Okay. If it is defect in GTP cyclohydrolase, then it is also non-classic phenylketonuria or phenylketonuria type 4 and 5. Okay. So, more common is this. More common out of these two is defect in dihydrobiopterin reductase. Okay. So, In any case, what will happen, that tetrahydrobiopterin will not be formed. Okay, and this tetrahydrobiopterin is required for two more enzymes. Tetrahydrobiopterin is required for phenylalanine hydroxylase. It is required for tyrosine hydroxylase. It is required for tryptophan hydroxylase, right? So, tyrosine hydroxylase will also be affected. Now, let's see the options once again. So, tyrosine hydroxylase is also affected when tetrahydrobiopterin is not available. So, answer will be this. Conversion of tyrosine to dopamine will be affected, right? So, let's read question line once again. Keeping this information in mind, which one of the following conversion is not occurring properly in this child? Okay, so answer is tyrosine to dopamine conversion, right? Coming to question number 3. Carcinoid tumor cells produce large quantities of 5-hydroxyindole acetic acid with the help of aldehyde dehydrogenase, which is then eliminated in the urine. Right, we know that 5-hydroxyindole acetic acid is a product of serotonin that is coming in urine, right? Which of the following metabolic end product of tryptophan metabolism directly give rise to hydroxyindole acetic acid? So, answer here is serotonin. So, let's see the biochemical reaction occurring here. Tryptophan, I am writing TRP for tryptophan. Tryptophan hydroxylase is the enzyme, and this enzyme requires NADPH, tetrahydrobiopterin and vitamin C. Then we get 5-hydroxytryptophan. So, tryptophan gets converted to 5-hydroxytryptophan. Now, we get 5-hydroxytryptamine, and the enzyme here is decarboxylase. Any decarboxylase which is doing simple decarboxylation requires vitamin B6. Okay, so this compound which is formed, 5-hydroxytryptamine, that is called serotonin, right? That is serotonin. Now, serotonin gets converted to melatonin by acetylation and methylation steps occurring, right? On the other hand, serotonin has its end product as 5-hydroxyindole acetic acid, which is given in the question also, and the enzyme is, aldehyde dehydrogenase. Okay, so read the last line of the question once again. Which of the following metabolic end product of tryptophan, right? The metabolic end product of tryptophan here is serotonin. That is directly giving rise to hydroxyindole acetic acid, right? Then coming to question number 4, a 3-year-old boy is brought to the emergency room with abdominal pain. Mental status changes. So, there is little mental status changes, fatigue and abdominal pain. So much of abdominal pain that the child is rushed to the emergency room. On taking history, the physician finds the child belongs to a very poor family and lives in an old house and has habit of licking the paint. Paint has lead. So, this is a case of lead poisoning. Licking the paint chips that have crumbled in the windowsills. The physician suspects lead poisoning. Lead typically interferes with which of the following enzymes? So, lead affects heme synthesis. So, let's do the enzymes of the first 2-3 steps of heme synthesis pathway. So, we have succinyl CoA plus glycine. These two compounds join together to make ALA. delta ALA, that is delta amino levulinic acid, and the enzyme is ALA synthase, which is rate limiting enzyme, and it requires vitamin B6. So this is first step of heme synthesis. Then ALA gets converted to PBG, that is porphobilinogen. Here this is second step, and the enzyme is PBG synthase, or this is also known as ALA dehydratase, right? Now after that there are many steps and we get protoporphyrin, right? This is protoporphyrin. Then there is 8th number step and heme is formed. In this 8th number step, iron is getting added. Enzyme is ferrochelatase. Enzyme is ferrochelatase, right? Now lead affects number 2 and number 8 enzyme of heme synthesis. So lead inhibits PBG synthase or ALA dehydratase, and it also inhibits the last step of heme synthesis, that is enzyme ferrochelatase. So what is the answer here? The question they are asking is, lead typically interferes with which of the following enzymes? This is PBG deaminase, no. ALA synthase, no. Coproporphyrinogen oxidase, no. So answer is ALA dehydratase. So which enzyme will be decreased in lead poisoning? Either number 2 or number 8th enzyme of heme synthesis. And in lead poisoning, when this second step is not occurring, ALA will be accumulated in the body, and also ALA will be coming in urine also, okay? And normally what happens is that this last end product, that is heme inhibits the rate limiting enzyme ALA synthase, okay? But in lead poisoning, heme is not getting formed. So ALA synthase will be activated, or ALA synthase will be induced or increased, right? So 3 questions they usually ask in lead poisoning. Which enzyme is decreased? It is either ferrochelatase or ALA dehydratase, right? Then which enzyme is increased? It is ALA synthase. And which compound is coming in urine? That is ALA, delta amino levulinic acid, okay? Then coming to question number 5. A 35-year-old man has history of intermittent abdominal pain and episodes of confusion and psychiatric problems. High amount of delta amino levulinate and porphobilinogen is also detected in urine. So ALA and PBG is raised. Patient has neurological problems and abdominal pain. The patient also has a mutation in the gene for uroporphyrinogen 1 synthase and PBG deaminase, porphobilinogen deaminase. The probable diagnosis of the patient is, so what is the diagnosis here? Let's see the chart of porphyrias. So this I have already told you, succinyl-CoA plus glycine makes ALA, then PBG, and then there are many more steps, and in the end heme is formed, okay? So in this question they are telling that PBG deaminase is not working, right? So that's why PBG and ALA, they have increased, right? They have increased in this patient. So this is a case of acute intermittent porphyria, and in acute intermittent porphyria only neurological signs and symptoms appear. There is no photosensitivity in acute intermittent porphyria, and in this patient also they have not given you any line of photosensitivity in the patient. So this is very easy question, that patient has acute intermittent porphyria where the enzyme affected is this number 3rd enzyme of heme synthesis pathway, which converts PBG to linear tetrapyrrole or hydroxymethylbilane, and the enzyme is HMB synthase or PBG deaminase. There is one more enzyme. When this linear tetrapyrrole is formed, there is a minor pathway where enzyme involved is uroporphyrinogen 1 synthase. So that is also mentioned in this question. So even if this enzyme is not working, then this HMB will increase, and they have also given PBG deaminase is also not working, and the compounds increased are ALA and PBG, right? So let me tell you about the neurological sign and symptoms of porphyrias. Why it occurs? They always occurs due to block early in the pathway. There is block early in the pathway when ALA and PBG they are accumulated. ALA and PBG they block the action of GABA. GABA is inhibitory neurotransmitter. So when GABA action is blocked, then there will be excitation in brain cells, especially excitation of visceral pain fibers occur, right? Now when excitation of visceral pain fibers occur, this leads to acute abdominal pain crisis. There is severe abdominal pain in these patients. Other signs and symptoms are vomiting, constipation, muscle weakness, tachycardia, and hypertension. So these are other neurological signs and symptoms. And in acute intermittent porphyria, only neurological signs and symptoms occur. There is no photosensitivity, right? Coming to question number 6. A 44-year-old male is concerned about his risk of heart attack since his brother just had a heart attack at the age of 46. His physician orders an HbA1c, lipid panel and homocysteine level. His blood shows high homocysteine levels. So this is a case of homocystinuria or homocystinemia, right? So homocysteine levels are raised in blood, and then homocysteine is also coming in urine. To be very precise, we say that it is homocystinuria because homocysteine comes in urine and homocysteine is increased in blood. Homocysteine is increased in blood. Homocysteine is coming in urine. So the disease name is homocystinuria. Now, what is the question they are asking? Which one of the following amino acid is not metabolized properly in the blood? So, this homocysteine is a intermediate product which is formed during the metabolism of sulfur containing amino acids. Sulfur containing amino acids are methionine and cysteine. So in the options, cysteine is not given, so answer will be methionine, right? So let's see this biochemical cycle of methionine. So what happens that in diet we take methionine because it is an essential amino acid. Then methionine gets converted to SAM, that is S-adenosyl methionine. Here ATP is used and all the 3 high energy phosphates of ATP is broken in this step, right? Then SAM is a methyl donor. So any acceptor can take methyl group from SAM and gets converted to methyl acceptor. On the other hand, when SAM donates its methyl group, it gets converted to SAH, that is S-adenosyl homocysteine. Now, adenosyl group is removed from this compound and we get homocysteine. Now, homocysteine gets converted to methionine again and the cycle is completed. And during the conversion of homocysteine to methionine, there is requirement of vitamin B12 and vitamin B9. So this is tetrahydrofolate, that is B9, this is cobalamin, that is B12, right? Now, on the other hand, homocysteine also gets converted to Cysteine. Cysteine is another sulfur containing amino acid which is non-essential because you can see here that it is getting formed in body. So, let's see the enzymes involved. First enzyme is CBS, cystathionine beta synthase, which requires addition of serine and one vitamin, that is vitamin B6, and it makes cystathionine. Cystathionine is formed. Then cystathionase enzyme, which again requires B6, and cysteine is formed. Okay, so we can say that for cysteine synthesis we require three things, that is serine, the amino acid serine, amino acid methionine, right, and vitamin, that is vitamin B6. Okay. Now, what happens in homocysteinuria? How homocysteinuria can occur? If this enzyme is not working or this pathway of cysteine formation is defective, then homocysteine will be increased, or if there is deficiency of vitamin B9 or B12, then homocysteine is not converted to methionine. Then also homocysteinuria can occur. And homocysteine is a dangerous compound because it can lead to atherosclerosis, myocardial infarction, pulmonary embolism, and stroke kind of conditions. So it is very, very dangerous. That's why history of this question says that patient has high homocysteine and a risk of heart attack, right? Then coming to question number 7, omega-3 fatty acids are found in oily fish and are considered beneficial for heart. Yes, omega-3 fatty acids, or you can say PUFAs, polyunsaturated fatty acids, they are very essential. They are also called essential fatty acids, and compared to omega-6, they are more beneficial for heart, right? Now, the question is, a food containing which one of the following would not fall into this category? Omega-3 fatty acids are 3, alpha-linolenic, icosapentaenoic, also called timnodonic acid, and DHA, docosahexaenoic acid, also called cervonic acid. Okay, so these three are omega-3 fatty acids. So answer will be option D here. This is gamma-linolenic, that is an omega-6 fatty acid. Other omega-6 fatty acids are linoleic and arachidonic. Okay, do this topic of PUFAs nicely, it is very, very important. Coming to question number 8, a 10-month-old child, 10-month, had normal growth and development for the first few months, but growth started deteriorating gradually along with symptoms such as deafness, blindness, atrophied muscle, inability to swallow, and seizures. So brain is affected in this patient. A cherry red macula. So cherry red spot. Cherry red spot is a characteristic feature of sphingolipidosis, right? So cherry red macula was also noticed in both eyes during the fundus examination. Suspecting sphingolipidosis, the physician tested for globocytes and ganglioside levels and found that both were increased. So globocyte, ganglioside, they are increased, right? Based on this finding, what is the most accurate diagnosis for this patient? We have two types of GM2 gangliosidosis, that is Tay-Sachs disease and Sandhoff's disease. When in this question they say both globocyte ganglioside is increased, then I will mark Sandhoff's disease, right? It will be clear on next slide. So have a look. GM2 gangliosidosis, one is Tay-Sachs disease, other is Sandhoff's disease. In both, primary organ affected is brain, right? Now, the deficient enzyme in Tay-Sachs disease is only hexosaminidase A. But in Sandoff's disease, it is hexosaminidase A and B both. Then which is the lipid accumulating in them? In Tay-Sachs, only gangliosides, that is GM2 gangliosides. In Sandoff's, gangliosides also and globoside also. Then clinical feature, in Tay-Sachs disease, mental retardation, blindness, muscular weakness and cherry red spot. In Sandoff's disease also, brain is affected. Patient has macrocephaly, hyperacusis and cherry red spot. So, answer to this question is Sandoff's disease. Coming to question number 9. A 1-week-old infant presented with relentless vomiting, watery green diarrhea, abdominal distension and failure to thrive. Further examination showed hepatosplenomegaly, an increased level of cholesterol esters, increased levels of cholesterol esters and triglyceride in plasma. X-ray showed calcification of adrenals. This is characteristic feature of Wolman's disease. The child most probably has defect in which of the following? In Wolman disease, the enzyme defective is lysosomal acid lipase, right? So in Wolman's disease, this is also known as cholesterol ester storage disease. Patient has watery green diarrhea, relentless vomiting and characteristic feature is calcification of adrenals. This Wolman disease is not a sphingolipidosis, but it's a lysosomal storage disease. Okay, so answer is option D. Look at option A, acid maltase. Where is this enzyme deficient? Acid maltase is deficient in Pompey's disease, which is type 2 glycogen storage disease. That is also a lysosomal storage disease, right? Then option B and C, acid phosphatase and alkaline phosphatase, their deficiencies are very rare, so no need to read that, okay? Then question number 10, a newborn has severe respiratory problems, showed little development. In few days, he had severe muscle and neurological problems. So, muscle and neurological problems, respiratory problem. His liver biopsy revealed normal enzyme levels of gluconeogenesis, glycolysis, citric acid cycle and HMP shunt. So, there is no problem in these 4 pathways, right? But a very low level of acetyl-CoA carboxylase. Where is this enzyme involved? Acetyl-CoA carboxylase is the first enzyme of fatty acid synthesis which converts acetyl-CoA to malonyl-CoA, and then malonyl-CoA is mainly used by second enzyme of fatty acid synthesis to make fatty acid, right? So, if malonyl-CoA is not formed, then fatty acid is not formed. So, let us see what is the question they are asking. The most likely reason for infant's respiratory problem. See, why respiratory problem? Because surfactant is not there. What is a surfactant? The main surfactant is lecithin. What is lecithin? Lecithin is dipalmitoyl phosphatidyl choline. What is this dipalmitoyl phosphatidyl choline? We have glycerol plus 2 fatty acids. These fatty acids are palmitic acids plus phosphate plus choline, right? Now, in this question, they are telling you acetyl-CoA carboxylase, the rate limiting enzyme, the first enzyme of fatty acid synthesis is not working. So, fatty acid is not formed, that is these 2 fatty acids, this palmitoyl acid, palmitic acid, 16 carbon fatty acid, this is not formed. So, lecithin is not formed, that is why the patient has infant respiratory distress syndrome, right. So, see the options: glycogen depletion, ketoacidosis, high level of citrate, low level of phosphatidylcholine. So, answer is this: low levels of phosphatidylcholine, right? So, congratulations for completing this video. I salute your dedication towards your studies and best wishes for your exam. There will be minimum 5 parts to this clinical biochemistry series, so subscribe the channel to get notified.